we will be talking about the topic is very interesting and also maybe this for discussion for the trauma, and scarring, the core and prevention and the management. Please for your presentation, Dr. Khai.
Thank you, Professor. Professor Sun, Professor Long colleges. Today I'd like to present on the eyelid scar after trauma, which are the causes, how to prevent, and how to manage the eyelid scars. I will discuss the anatomy of the eyelid. Behind this eyelid scar, the causes of bad scarring, how to prevent the scars, and the management strategies once you've got the eyelid scars. So as you all know, the upper eyelid and lower eyelid has two main layers, the anterior and the posterior layer. The anterior has the skin and very thin subcutaneous tissue, and under the skin the orbicularis oculi muscle. And in the posterior layers we've got the tarsus and levator aponeurosis on the tarsus, and behind the aponeurosis is the mural muscle, and behind all the conjunctival lining the inner surface. So the function of the eyelids is to protect the globe and to distribute and drainage to drain tears. If we have a malfunction of the eyelids, the globe will have risk on perforation and risk for visual loss, and the patient have tearing. So which are the causes which contribute to eyelid scarring? So normally the main causes we've got is complicated trauma, where we've got a lot of tissue loss and we cannot close the wound. Secondly, maybe it's because of the surgical procedure, the primary repair of the wound. We may have poor wound closure, excessive tension on the wound closure, or we may have wrong choice of sutures, or maybe we remove the suture too late. And there are other causes like delayed wound repair, like if the patient has systemic conditions like head trauma, we cannot repair the eyelid wounds in time, so it will get infection or other ischemic. So like this patient, she had a motorbike accident just before Tet holiday last year. He scraped her face against the surface of the road. So there was a large area of lost tissue. So at the first hospital, the doctors were unable to close the wound completely, and they leave a large area of open wound. So and the suture they used was too big, and so it created excessive tension on the wound, and it is a risk factor for bad scar and for contraction after the scar is healed. So we did a flap mobilization. So we mobilized this flap, and we advanced on this flap. We advanced on the flap up to close the wound completely with a smaller skin suture. So if the tissue loss is not properly addressed, the healing will be by secondary intention. Secondary intention, it means when we leave a wound open to heal on its own, and we have granulation tissue, we have hypopigmentation, fibrous scarring, and distortion of ligamentum if we leave tissue to heal by secondary intention. The ideal process is primary intention, where skin is epithelium of the skin is close together. A second cause that we often see is poor eyelid wound closure. At the first time, we didn't close it right, like this eyelid. The lid margin is not even. We can see that the gray line is aligned, but the tarsus is not aligned. It's not exactly aligned, so we've got this part of the lid elevated. And besides, the suture here is too large for the eyelid skin. So you have to take out all this suture to do it from the first step again. Another causes that we often see is wound not closed in layer. Because there are many layers on the eyelids, so when we close the wound, we have to close skin to skin, muscle to muscle, tarsus to tarsus, and sometimes septum to septum. But if we only close like one suture to all the layer from skin to muscle to tarsus, then we have fibrous band appearing between the skin to the orbital septum and to the orbital bone to the limiter aponeurosis. And then we have this contraction of the eyelid. Another causes of bad eye scar is excessive tension on the skin suture. Like this, we call this cross-hatching, which are the mark of the suture on the which cross the scar. So the cross-hatching is caused when there are too much tension, or if you leave the suture for too long. For example, more than 1 week, because the suture, too much tension and the suture cause ischemia of the deeper tissue, damages to the skin, and even stimulate excess collagen formation. And the timing of suture removal must be balanced between the needs of sufficient wound support. We cannot like remove the suture too early. But we must balance between the risk of developing cross-hatching like this. Normally, suture placed in the face, I usually remove around 5 to 7 days after surgery. But in the case of eyelid, we can remove it like earlier from day 3 to day 5, such as on the eyelid. Another causes of atrophy scar, which is very difficult to treat, is wound lesion. We often have atrophic scar on face because when the scar edge, it constant movement, it moves a lot. Because the face have a lot of muscle, so the wound on the scar often get lesion and sinking of sin into the wound, and it cause atrophic scar like this. Normally, atrophic scar we have more in children because children have much more face expression than adults. And when you have animal bites like dog or cat bite, because the saliva is very rich in proteolytic enzyme, so this enzyme will prevents the scars to heal, and is often infected. So what do we do to prevent the scar of the eyelids? So there are like 4 things to do. The first is accurate alignment. We have to close the lid in layer between layer, and the lid suture is very important. And after the wound closure, we got to place in the tarsorrhaphy suture or first suture. So I just quickly remind the repair the full thickness eyelid defects. So before the operative, we have to evaluate if the defect size is less than 1/4 length of the eyelid. We'll do a direct closure. If it's more than 1/4 of the eyelid, we have to do the cantotomy or cantolysis. We'll then use a forceps to assess tension and to oppose both edges. If we have a cross injury and an irregular defect, the tarsus place in cross, for example, we have to trim the edge to a beautiful wedge. But otherwise, we've got to preserve as much tissue as possible because the tissue on the eyelids is very important. So after we have trimmed the defect, we'll do the suture technique. So there are 2 suture techniques we can do. The first is straight suture, where each suture is placed parallel to each other through the eyelash line. through the gray line and through the meibomian gland line. Or a second technique can be do is a vertical matrix. You can go in from the far side to the far side and go in from the near side to the near side. So why do you do this vertical matrix? I'll explain later. After we have done the margin suture, we do a tarsal plate alignment before we tie the margin suture. So we close the tarsal plate with 6 vicryl and about 2 or 3 parallel suture like this. But the suture is not exposed at the conjunctival size, or we have a risk of corneal abrasion. After we have done the tarsal plate alignment, we will re-evaluate the margin and then tie in the margin sutures. And then we do the skin and muscle closure layer by layer. Okay. So why do we do the vertical matrix suture? Because we need an inversion on the lid margin. Normally, we often think that if you have a smooth, flat margin, it will be a beautiful closure, but this is not the case. If you have a beautiful, like smooth, flat margin like this, after the healing of the scar will be shortened, and then you have a V shape, and then it is called a notch of the eyelid. So, don't do this. We have to do a inversion of the edge. So we have a little bit protrusion of the wound like this. After like three months, the wound have healed, and we have a flat, smooth, flat margin of the eyelid like this. So the vertical matrix suture will help us to do the wound inversion. Another important thing is to do the deep suture. The deep suture. So how do you do the deep suture? We bury the knot so we come from deep to superficial, and then we come to the other side and go from superficial to deep, and then the resulting knot will be buried deep into the surface. So why do you have to have this deep suture? Because if we got a good deep suture, we don't have to put much tension on the skin, and then we don't have the cross-hatching like we saw before. And then when you close the skin, don't hold the tip of the needle holder like this, and don't crush the skin with a forceps like this. So ideally, we'll close the skin with a skin hook like this. You just touch the skin and hold it. Or if you don't have a skin hook, we'll use a forceps with tooth, and then put one side of the tooth to hook up the skin, and then we'll put the suture in. So this is the right way, so not to damage the skin edge when we close the skin. And after we have closed all the laceration, we put a taphoraphy suture in here. So it will, or frost suture at the peak of the wound. So we prevent the fibrous adhesion formation, and it will keep the scar, prevent it from being shortened. And the post-operative modalities to prevent hypertrophic scar. We got a lot of studies on intradermal botulinum toxin right after we have closed the scar, and even when we have a scar, a bad scar. And then we have wound dressing like silicone gel or silicone sheet, and topical steroid, and with massage. It is very popular in Vietnam to use topical onion extract, and we know it as contractile-based ointment, and other things that these are the most popular thing we do to prevent the hypertrophic scar. So, if we already have a scar, what do? The first thing is to not do anything at all. So we've got to delay the revision of the scar. And then we have to apply all the non-surgical management. And then when we decide to do the revision surgery, we have to analyze carefully the components of the scar. So we will do that. Why do you have to delay? The first thing is to avoid reoperating within 1 week, because we will have excessive bleeding. The local inflammation will temporarily weaken the tissue, so the suture tears easily. We cannot suture it again. And we have to delay as long as possible for the scar to mature and for the tissue to remove them. So the minimum timing is 2 to 3 months, but ideally we revise, we repair the scar after 6 to 12 months. Why is that? Because we've got 4 phases of scar forming. The first phase is in 1 hour, that is the clot formation. In the first 3 days, we just use antibiotic ointment because it's the inflammation phase. So the third phase is where you use the non-surgical treatments, like on the massage and steroid, because it's the proliferation phase. So it will be 3 weeks. And then from 3 weeks to 1 year is the scar remodeling. And it is the time where the contraction of the scar happens. So we'll wait for the scar to shape, to remodel completely. Then we'll repair the scar. There are a lot of non-surgical options, but normally we don't do much of it because we send the patients to dermatologists. So what we popularly do, first we do the massage of the scar. So normally we tell the patient to massage a little firmly toward the margin with steroid ointment about twice a day for 5 minutes for 2 or 3 months after the trauma. So topical silicone gel and topical silicone sheet is quite popular. It will flatten the scar, so we won't have a hypertrophic scar. Steroid injection is quite popular too. We can use more invasive treatment like microdermabrasion with a small brush like this for like a hypertrophic scar, but it has a risk of dyspigmentation, so it's not very popular. Here, if we have a hypertrophic linear scar, we can use low-dose triamcinolone, like Kenacort, from 5 to 10 milligrams per milliliter up to 40 milligrams per milliliter, and it can be repeated monthly until the scar is flattened. So you inject it just into the scar body, and we do not inject out into the healthy skin because we have the atrophy of the healthy skin. We can combine it, or we can inject 5-FU alone, or combine triamcinolone with 5-FU from the ratio 1:1 to 1 triamcinolone with 10 5-FU. And at last, when we do the scar revision, sometimes we do very simple procedure like this. This patient has a V-notching of the lip margin, so we just trim the scar again with to cut out the wedge resection, and then we release the lateral angle, and then close the scar with an edge eversion, and then 6 months after the repair the scar. Normally we do a zit-plasty. So with a shortening scar like this, the body of the zit will be the scar, and then we cut out a zit with 2 flaps, and then transpose the 2 flaps. So we've got a longer zit. Like this patient, has maybe like many repairs. This after the primary wound closure. So we've got quite a lot of adhesion like on the upper eyelid, so that he has a skin graft in here. But after some time, the skin graft also contract, and he still has a contraction, retraction of the upper eyelid. So this time he had the lower eyelid revision. We did a refixation of the middle angle of the lower eyelid. So this is after the second revision. It still has an upper lid retraction and fibrous band adhering to orbital bone. So we do an analysis for this patient. So the skin rapidly done, but he still have the lip margin notching. So we've got to do a wedge resection and a lateral canthotomy and do a unclosure erosion. But he also have an adhesion between the skin levator and the levator aponeurosis. So we've got to fix the fat pad. So we insert the fat pad between the skin and the aponeurosis. But still it has a skin retraction like this on the surface. So we have to do a Z-plasty of the skin. So after these three procedure combination, we've got this patient. So he has a smoother lip margin, reduced peak of the margin, a lengthened, like longer scar compared to this, and no more like ophthalmos. Sometimes one Z-plasty is not enough, so we've got to do a multiple Z-plasty. So what is a multiple Z-plasty? So we've just do all W plasty. So we just excise the scar, and then we excise the edge with the W edge, and then we fit the edge of the W together. So the tension will be in every direction, and so we don't have a very ugly scar like this, but it is like less significant cause. Sometimes in the medical cases, we have to do Y2V advancement or a Pax Z-plasty or V2W plasty, or sometimes modify Y2V like this. We just cut out a half a circle, and then we just close it like this. Or in severe case, we have to do a transnasal wiring with steel suture. So this patient have a Y2V advancement and a jaw strip too, because he has a canalicular laceration. This another patient who is very complicated. So after the primary repair, he has a big ptosis and a very ugly scar. The first revision has done after like several canal cord injection. So we've got this after the first revision elsewhere. He has a schizoid and Y2V advancement of the medial canthus and a levator recession. But he's not pleased with this result. So we did a second revision. So we excise the scar again and close with broken line, and then we did another Y2V advancement, and we did a frontal flap sling for this patient for his ptosis. And again, some like episode of canal cord with 5FU injection. It seems that he is quite pleased with the result now, but is there any other revision we can do? Maybe the next time I do I increase for him. Sometimes in my case, we have to do a transverse release plasty, which means we have a short scar. We will transpose into a long scar like this. So you just cut from the scale B to B1 is the scar. So we cut A to A1 like this, and then we will close the muscle from A to A1, and then we close the skin just perpendicular to the first scar. So this is like a